Now we're going to get to the guts, right? Talk about GI. And we'll start kind of a tour of the system, and we'll start with things like that you see all the time, gastroesophageal reflux disease. It's not just a lowering of the GE sphincter pressure, it's multifactorial, and probably at least 1 in 10 of you have some heartburn or will have heartburn depending on how much you indulge tonight. And so you can see things like medications can do it. So a lot of your cardiac meds, calcium channel blocker, morphine, all of those can cause that. And when we look at this, we get some complications as a result of that. Chronic reflux disease can increase cellular change. You can get Barrett's esophagus, leading to a low rate of adenocarcinoma of the esophagus. You can get strictures. You can get erosions and bleeding. You can get extra GI manifestations, so worsening of asthma or aspiration pneumonia, and even something as mundane as dental erosions and cavities. The diagnostic test really has become more of a PPI trial. See what happens in a response to 2 weeks. If they're not better, then you might consider further evaluation. You can do pH probe monitoring. You can do EGD. You can do esophagram, but not usually first line. And the treatment here, it's pretty effective. PPI is equal to distant fundoplication without all the surgical complications. H2 blockers, which is what our insurance companies want to start with, are not as effective, about half the rate of the PPI. So again, if you can do a PPI trial for 2 weeks, they should be improved. Who are the patients that you screen because they've had GERD symptoms? If they have any alarm symptom, bleeding, weight loss, anemia, difficulty swallowing, they need to have that mucosa looked at with an EGD. If you've been treating them and you've gone even to twice a day high dose PPI, and after 4 to 8 weeks, their persistent symptoms not getting any better, you need to look at what's going on in the mucosa. And obviously, if you have somebody that's already had erosive esophagitis, they need to be repeated with about 2 months to see if they've got some healing. The other patients that are at increased risk for problems with GERD are over 50, smokers, and male with increased BMI. If they've had GERD symptoms intermittently on and off for 5 years that have never had a scope, some people would argue that these are also people that should be scoped. And how do we treat it? Initial lifestyle modification, elevation of the head of the bed, avoiding eating before laying down, avoiding those substances that cause decrease in the sphincter pressure, so things like caffeine, chocolate, lots of red meat, all the stuff that tastes good, just spit it out, right? And then we'll try acid suppression therapy. You can do a stepwise approach up, H2 to a PPI. And again, you would try, after the symptoms are better, to wean back off of the PPI and maybe back to the H2 or an intermittent PPI. That's probably better than continuing ad nauseum on your med list. This is sort of a workup, a key that you can work your way through. Again, looking at who does need to be further evaluated and who you can treat. The complication of Barrett's esophagus, again, squamous epithelium is replaced with columnar epithelium, which looks less like the esophagus and more like the lining of the stomach. And the published reports, some of the older literature says adenocarcinoma incidence up to, again, 10% lifetime or 0.1 to 0.2. It's probably closer to about 2%. Really, the definitive first study was in the VA, and somebody has to argue, if you look at study design, are your VA patients like your patients in practice? Probably not. And so there is higher risk. If you have Barrett's esophagus, what you're going to look at is it low-grade or high-grade dysplasia on the biopsy? If it's high-grade, the risk increases. And so again, we're going to do that based on biopsy. And then how do we treat people with Barrett's? Aggressive PPI and surveillance. You know, if there's no dysplasia, they say it's Barrett's esophagus, no dysplasia, you probably rescreen these every 3 to 5 years. If they have dysplasia and it's low grade, it's probably every 6 to 12 months. And if it's high grade, some recommendations are Q3 month EGDs. Now, what I have to tell you is that's based on recommendations, so it's a level C evidence. It does not have any trials that shows that there's a decrease in the incidence of adenocarcinoma, and certainly no decreased mortality data. Esophagitis, again, irritation of the esophagus can be caused by any number of problems. So it could be an infection, it could be irradiation, it could be an ingestion of a caustic substance like lye or gasoline or turpentine. It can be infectious like things like herpes or Candida. And so you have to look at the symptoms are pretty much the same. Difficulty with swallowing, pain with swallowing, and you have to look at the concomitant history and are there other clue factors that might lead you to the diagnosis. So here you want to know what's going on with the mucosa. So an EGD is often done with or without biopsy. You can look at acid perfusion, you can look at culture, but you really need to look at what the mucosa is and then treat specific based on the diagnosis. You can get, again, some of the complications with things like Barrett's and erosions or strictures. So here's a 67-year-old, comes in, has had difficulty swallowing, so some dysphagia, regurgitation, and he may not complain of bad breath, but the entire family chimes in, he has bad breath. And he's had some weight loss. What's our diagnosis? Mallory-Rice, rumination, Zenker's, multiple sclerosis. This is a patient with Zenker's, and I'm going to compete with our music here now. Zenker's is an esophageal diverticulum, if you will. It's a pulsion, outpouching of the distal esophagus, more common in men than women, usually over 60. They have those symptom complex of regurgitation, halitosis, dysphagia. They may stop eating because they get a sense that food is sticking. The diagnosis here is either a barium swallow, where you'll see the barium go into the outpouch, or esophagoscopy. And the treatment, if it's recurrent or symptomatic, is actually clipping that diverticulum. It's done outpatient. They go home same day. Usually your ENT surgeons can do that. We're still in the GE junction. Let's talk about Mallory-Rice syndrome, also known as the Saturday night special. Right? This is where you see these patients come in after prolonged forced retching, usually following copious amounts of alcohol, and they'll come in because they have vomited up blood or they passed melena. And it's a mucosal tear at the GE junction from forced retching. Usually will heal within 10 days. With rebleeds uncommon, occasionally you'll need surgery if it's a brisk or rapid bleeding. You can see esophageal perforation. They're both iatrogenic and spontaneous. Spontaneous goes by Boerhaave syndrome, where you actually perforate the esophagus with etiology unknown. You can see it especially in little kids that ingest all sorts of things. One of the more common things that you want to worry about are batteries. There's little button batteries. They increase the risk of esophageal perforation. They need to be gone after with EGD. These patients present with things like chest pain, subcutaneous air, sounds like alligator baggies when you push the skin. They may also have air in the mediastinum on a chest x-ray. They get sick quite rapidly. A lot of times they're treated both with cardiovascular surgery evaluation, needing chest tubes, mediastinal tubes, and broad-range antibiotics. If you look also at the esophagus, some patients present with what we call achalasia, absence of peristalsis. And here these patients have dysphagia, they have regurgitation, they have weight loss. If you did a barium swallow, the classic description is a bird's beak type esophagus. The bird is upside down and on its head, and there's a small, thin line of barium that actually comes through this area of achalasia. The treatment here is, again, making the diagnosis. Gold standard is manometry to show absence of peristalsis, and then surgery is now becoming the gold standard, where they take out the achalatic segment, reconnect it. That can also be done under laparoscopic. If the patient is unable to tolerate that, you can do repetitive dilatation. You can use calcium channel blockers to try and relax that area, and you can use Botox. Some of these patients present with chest pain, and this, when you work them up and they're non-cardiac, They may have diffuse esophageal spasms. Some people call that the nutcracker esophagus, where they have tertiary spasms with high amplitude on manometry. And the treatment here is using a smooth muscle relaxant. So you're looking at things like a calcium channel blocker or nitrates. And the thing here is especially you work up these patients, remember they can have concomitant cardiovascular disease, and if you put a patient on nitrate because they have esophageal spasms, somewhere in the chart note that, because if you go to the emergency room and I see you're on nitrate, my first conclusion is you must have angina, and that may not be true. If you look at that coexistence, just remember not to forget that chest pain can coexist with GI pain. And the most common cause of non-anginal chest pain is probably psychogenic and some of your GI causes, and the list goes down from there. Now, dysphagia, again, affects a large percentage of the population, up to 10%. And what we talk about is there's two phases. There's oropharyngeal dysphagia, or disordered transfer from the back of the pharynx into the proximal esophagus. That's leading cause is stroke, so that's your bulbar dysfunction. And then there's also esophageal dysphagia, where it's past the initial upper third of the esophagus, where you have either absence of peristaltic motility or disordered motility. So things like neuromuscular diseases, mechanical obstruction. This would also fall into things like scleroderma. It affects the distal esophagus to become a lead pipe tube and it doesn't contract. Here again, EGD and motility testing are usually what help make the diagnosis. They can look at is dysphagia for solids or liquids or both. And we hear dysphagia that's solid, we have to think, is this mechanical, obstructive, ruling out esophageal cancer would be the first thing we want to think of. There are some patients that get this because they're fast eaters, and that's none of you doctors in the office, right? In the audience. Then you can get a constriction ring called Schatzki's ring, and then that relaxes. I like to describe that as like you swallowed the peanut butter sandwich the wrong way, and it's stuck right there. If it's solid and liquid, it usually points more to a neuromuscular or the things like scleroderma. You can get painful swallowing, and again, etiology is a multitude. It can be infectious. It can be things like Candida or herpes. It can be CMV in the immunocompromised patient. It can be what we give them, so pill-induced esophagitis and painful swallowing. So things like nonsteroidals, iron, or bisphosphonates. So we're going to come out of the esophagus, go into the upper GI. 80% of acute GI bleeding is upper GI. So if you're going to look for the bleed, start in the upper region first. We'll see things like peptic ulcer disease, Mallory-Weiss tears, varices, and associated with cirrhosis. And so again, if you're looking for someone coming in with a GI bleed, you can look at upper first. The presentations, if they're having a bleed and they're not vomiting, it may be tarry stools. They don't take a lot of blood to get that black tarry stool. If they have hematochezia or maroon red-colored stools, it's a massive bleed, and it's really triggered the GI tract to move things along. They'll look at about 1,000 mLs to get a really good maroon stool. And then if they have hematemesis, where they're coughing up those coffee grounds, also one of the causes of GI bleeding. Our stabilization is like anything else. You want to do immediate stabilization. You want to maintain the pressure. You want to then find out the cause. So you can either do endoscopy and then treat definitively, or NG can also help in terms of at least decreasing blood in the stomach. And then our ultimate goal is prevent rebleed. And who gets the problem with rebleeding? If you're older, you've already had hematochezia, you've required greater than 5 units of transfusions, these patients are going to do worse. And you can look at the predictors there. Why is that important? Because these patients often go to the ICU, and if you're going to look at rates of rebleed, they occur usually around 72 hours and beyond. And so if you look at somebody that has a clean ulcer bed, the rate of their rebleed is much less than if they have visible arterial spurting. And by combining those factors, you can predict who's going to be able to be discharged out of the ICU to the floor. Because it usually happens about 3 days, and usually about an hour after you transferred the patient to the floor, right? You get that stat call. How do we treat it? We can do endoscopic treatment with thermal coagulation, injective therapy, clips, combinations thereof. And then what we're going to do is put these people on anti-secretory medication, H2 blockers, not good evidence, the PPI better. And if they're really bleeding, we could do things like prokinetics or somatostatin. Very rarely does a patient need surgery, but there are still those patients that have a recurrent bleeding and that you may have to take them to surgery for an overso. And then our prevention is, do we have H. pylori? If we do, we need to treat it. We should probably tell them to stop smoking and avoid risk factors, i.e. things like nonsteroidals or anything that can cause esophagitis or gastritis. So let's talk about H. pylori. H. pylori is an interesting story, and that's associated with peptic ulcer disease. It's associated with gastritis, non-ulcer dyspepsia, and even gastric carcinoma, adenocarcinoma. Also associated with GERD, and there's a subset of the lymphomas called the MALT syndrome, where you have mucosal-associated lymphoid tissue associated with H. pylori. So if you can treat and eradicate the H. pylori, you can either get remission or cure of a lymphoid-associated tumor. Who do we test, or who do we want to look at screening? Anybody who has active peptic ulcer disease or a past history of peptic ulcer disease that hadn't been screened before. If they've had recurrent GERD symptoms, you might consider that. And you can do it either endoscopically with things like a Clo test, or non-invasive with things like serology or stool assay. Actually, just read a recent article that said probably the easiest and most accurate is your urea breath testing, can be done in the office and gets fairly quick results and is pretty sensitive and pretty specific. The initial therapy, again, you could talk about triple or quad therapy. What you really need to know is what is the resistance pattern of H. pylori in your community. And so calling the hospital and asking what's their biogram for H. pylori, because there is increasing resistance with the initial triple therapy, and you may need to go to the quad therapy. And then you often sequentially follow that. So if you've done triple or quad, there is a salvage therapy, and up to 20% of patients will fail first round or second round, and so you switch out the antibiotic. And so you may end up with things like amoxil levofloxacin and a PPI BID in order to eradicate H. pylori. What about dyspepsia? Again, the most common is functional dyspepsia, and the big debate is, what do you do with these people? Do I scope them all? Do I put them all on a PPI? Do I test all for H. pylori? And the answer is yes, because we don't know what's the best one. A third of these patients resolve spontaneously despite what you do, or maybe because of what you do. And so, again, we have to realize this is fairly common. If they're over 60 and they come in, they probably should have an EGD. If they're less than 60, you might consider non-invasive H. pylori testing and treat appropriately. And if the H. pylori is negative, you might try a trial of a PPI and a prokinetic agent or an antidepressant, because all of those have equally efficacious outcomes. All right, gastroparesis. Anybody see gastroparesis, right? You see it, I think it's following the trend of increasing type 2 diabetes, where you have the syndrome of nausea, early satiety, bloating, sometimes postprandial pain. It's associated both with your diabetic, but also in certain selected gastric bypass surgeries, and certainly things like scleroderma, but also hypothyroidism can give you an acquired gastroparesis. And you diagnose it with a barium swallow or a radioactive test meal, and the radiologist will tell you how long does it take for that test meal to get out of the stomach, and they'll tell you, oh, this is 1,600 minutes before we got rid of the barium in the stomach. That's delay. They'll even say it's delay consistent with gastroparesis. The treatment is good hydration, good nutrition, good glycemic control if they're diabetic, and an acute exacerbation where they have, if you will, an acute onset of the symptoms, you take advantage of erythromycin side effects, giving it IV. It is a prokinetic agent. It will move things along. That's one of the reasons why nobody uses erythromycin orally, is the GI side effects. You can look at metoclopramide. You can get Zelnorm on compassionate trials. You can use gastric pacemakers, and if all else fails, you can bypass that part of the stomach and do things like a jejunostomy tube. Of course, that makes for them now being on enteral nutrition. All right, we're going to kind of talk about, I call them the big four in GI: nausea, vomiting, diarrhea, and constipation. And nausea, vomiting, diarrhea, and constipation are symptoms, not diagnoses. So when you talk to a patient and they say, oh, I'm nauseous, and you have to say, what do you mean by that? Do you mean like you're gonna hurl? Or are you already hurled? Or are you just retching where you're not bringing up any contents? Or are they regurgitating where they have food that comes up and then they swallow like a cow, back and forth, back and forth? Vomiting is a very complex interplay between neural, humoral, and chemical, and it involves both the gut and the brain. And so our history guides how we approach the patient with vomiting and nausea. So if they tell you they're pregnant, like in Barb, and they're at 10 weeks, maybe it's morning sickness. If they have acute vertigo and every time they turn their head they puke, it's probably things like labyrinthitis. One little hint, look at the hands. If you've worked up the patient and they can't come up with anything like nausea and vomiting, they may be bulimic or anorexic. And if you see scarring on the back of the knuckle, it's often a bulimic. If you don't have a clue, you might make sure you're not missing a low-grade intestinal obstruction. And don't forget, with nausea and vomiting, there are a whole host of chemical causes. So hypo and hyperthyroidism, glucose, hyper and hypo, calcium, hyper and hypo. All of those can cause motility disturbances and increase rates of nausea and vomiting. The treatment here, again, if it's nausea or vomiting, you want to use something to sort of suppress that reflex. So the 5-HT3 antagonists are often first line, except in pregnancy. You can still use things like Phenergan and Compazine. If you need to, you can use a little dexamethasone with a combination, and things like metoclopramide may be also very useful. If it's related to something like vertigo, antihistamines, anticholinergics may be helpful. All right, diarrhea. And I love this when patients say, I have diarrhea. And I ask them, what do you mean? Now, I can't say, did you pass greater than 200 grams of stool today? Most people don't measure that. And if they do, I get worried. And I call my psychologist. But it's 3 or more loose watery stools. A lot of patients say, I have diarrhea. And you say, how many stools a day? 1. That's a loose stool. It could be a watery stool, but it is by definition not diarrhea till it gets 3 or more. And then we just divide, is it acute or chronic based on 4 weeks. You can go, if you want to be a splitter, is it an inflammatory or a fatty or a watery diarrhea? And why do we care? Because it's fairly common. All of you will have at least about a diarrhea once this year, maybe more. It is the second leading cause of death worldwide, especially in children. And so the big dilemma is, who do I need to treat and who do I keep my hands off? They're going to get better anyway. So here's a patient who has diarrhea for 3 weeks. What's the major challenge? How do I evaluate? Do I evaluate based on the history? So if they are showing signs and symptoms of dehydration, if they've got blood or mucus in the stool, if they have a high temperature greater than 103, over age 70, or have a history of immunocompromise, those patients probably need to have further evaluation. A comment about stool leukocyte testing: don't waste your patient's time and money. Its sensitivity and specificity is 50%. You might as well flip a coin. It doesn't help you. What you really need to do is, do I need to do endoscopic exam? Am I thinking the history leads me to C. diff? Do I think about ischemic causes? All of those may be helpful with endoscopy. And stool culture and for bacteria and ovum parasites are really driven by the history. They should not be a reflex. Oh, I got stool cultures and ovum parasites. Get the travel history. Get the history of immunocompromise. Are they institutionalized? Are they imprisoned? Do they have sex with other men? All of those will flavor how you want to evaluate them in stool cultures. You only need a single stool culture if you're looking at bacteria because it's shed continuously. You need 3 for ovum parasite based on the life cycle of the parasite because sometimes you're not so lucky to catch it on the first sample. You may need to have it 3 days in a row. And then there's a whole host of causes that are non-infectious. So medications can do it. I mean, if you can find me a drug in the PDR or the compendium that doesn't cause diarrhea, constipation, nausea, and vomiting, I will buy you dinner. I haven't found it yet. Food allergies, sensitivities, inflammatory bowel disease, irritable bowel disease, thyrotoxicosis, carcinoid syndrome, all can cause diarrhea. And so if you look at some of the common pathogens and we try to divide, is it large bowel, is it small bowel, it's sometimes helpful, but it's not discrete. And if you look at some of the pathogens, we say, oh, salmonella is usually more in the small bowel, except when it's not. Then it's in the large bowel, right? Campylobacter, usually in the large bowel, but it could be in the small bowel. So you can look at some of the more common infectious causes. And then you look at viruses, probably the number one is our norovirus. We're seeing less of the rotavirus courtesy of our vaccine, but we still see it. And then some of the protozoans, depends on where you are in the world, and the things like Giardia, Entomoeba, that sort of thing. Norovirus, I said, predominantly the number one reason worldwide. It is foodborne. We see it in certain areas of the country with vegetables, fruits, shellfish. Treatment is really isolation and hand washing. Salmonella, second most common foodborne illness in terms of bacteria, usually poultry, eggs, and contaminated milk products. Usually the biggest thing is not to treat them because they usually resolve. And in fact, if you treat them, you may prolong the course of the infectious rate of 2 or 3, 4 weeks. Shigella, again, a very infectious agent, goes through daycare and institutional settings rapidly. Treatment here is either quinolone or trimethoprim sulfa. Bacillus cereus is a preformed staphylococcus toxin. This is the post-picnic diarrhea that patients get usually within 4 to 6 hours as a result of the toxin. In Campylobacter, things like uncooked poultry has been linked to Guillain-Barré. We really, again, symptomatic treatment most of the time, and only in severe cases do you treat with things like macrolides. The E. coli, again, the story there is the 0157H7 undercooked beef associated with hemolytic uremic syndrome. There was an outbreak of this traced back to contaminated beef in Jack in the Box about 15 years ago in the Northwest Corridor. The treatment, again, not recommended. I mentioned C. diff because it can cause diarrhea. I know the ID people are going to talk about that. Chronic diarrhea lasts more than 4 weeks. It can be things like parasitic, infection, viral, and a whole host of things like Crohn's disease, ulcerative colitis, radiation, ischemia. And our symptom here is they have consistency, a harder stool, they may have fecal soiling, and we look at how long have they been lasted and look at the different histories. And so again, looking at that chronic diarrhea. Specific testing, you can look at stool electrolyte, you look at stool fat, you can look at fecal pH. I guess that depends if you want to be the stool aficionado, right? But a lot of times the history helps you with that. The fecal fat, you don't necessarily have to characterize. These are the patients that have loose, watery stools. It looks like an oil slick. It doesn't flush. These may be the steatorrhea stools. They may be the ones that look for exocrine problems with the pancreas, especially in patients that have had chronic inflammatory pancreatitis. And then don't forget that some of these patients will come in complaining of diarrhea and they're purging, so you may consider laxative assays. You can look at things like the carcinoid syndromes. You can look at things like our pheochromocytoma and even weird tumors that secrete vasointestinal protein. These are more common causes of the different kinds of diarrhea, I'm not going to belabor that. How do we treat that diarrhea? Made at the diagnosis. Sometimes before you go all out, you might consider a course of metronidazole to see if that diarrhea doesn't improve. And you can certainly treat them symptomatically with things like loperamide. Here's a 39-year-old, duodenal biopsy for sprue. It confirms the diagnosis. Correct statement regarding the treatment is avoidance of wheat, rye, and corn, cereal, gliadin, or anti-endomycelial antibodies, prednisone, or improvement with gluten-free diet. The answer is improvement with gluten-free diet. Gluten-free diet or sprue enteropathy is way more common than was initially thought. If you go back and pull a GI text from 20 years ago, they say it was 1 in 5,000 to 1 in 15,000. We now know it's anywhere from 1 in 100 to 1 in 300. There are populations that it's rare in, so Chinese, Japanese, and African descent, but it's much more common if you're sensitive to things like wheat, barley, rye, and oats. Diarrhea, by and large, is the predominant symptom, but you can see iron deficiency anemia. These are the patients that may have accelerated osteoporosis because they lose their fat-soluble vitamins. And it is also associated, when you see sprue, check your thyroid, and there is an increased risk for lymphomas. The treatment here of a diagnosis is the IgA anti-tissue transaminase, or otherwise known as IgA anti-TTG antibody. It's both sensitive and specific, and it's really replaced the older assays of IgA endomycelial or anti-gliadin antibodies. And it's also really replacing the duodenal biopsy as the gold standard. If you haven't diagnosed sprue, you haven't looked for it. It's in your practice. And then finally, there's a weird cause of diarrhea called microscopic colitis. The only way to diagnose this is with a biopsy. If you're looking on colonoscopy, the colon looks normal, but when you biopsy, you see an underlying inflammatory component, usually with things like eosinophils, and then you treat them with loperamide, budesonide, cholestyramine, and the diarrhea resolves. And people go, I've never seen this. The last time I took boards, they had a question about microscopic colitis. So worth considering, especially if your entire workup is negative.